Hello, everyone. We are second year Doctor of Occupational Therapy students from St. Ambrose University, and today we are going to be educating you on OT's role with Parkinson's disease.
So on the agenda for today, we're going to have you go ahead and complete a pre-test just to kind of check your knowledge before we give you the lesson. And then we're going to go over the introduction to the diagnosis of Parkinson's disease, the assessments that you would use for this disease, intervention methods, outcomes, modifications, and adaptive equipment for the home, and then the post-test to see what you have retained. So at this time, go ahead and pause the video and use your phone to do the QR code on the screen, and then you'll take the pre-test.
So to start with the introduction to the diagnosis, a brief description is Parkinson's disease is a chronic progressive neurodegenerative condition associated with progressive synucleinopathy, degeneration of dopaminergic neurons in the substantia nigra, basal ganglia dysfunction, and widespread functional brain network disruptions. Motor symptoms and non-motor symptoms are apparent in this disease. There's bradykinesia, akinesia, rigidity, postural instability, decline in initiation and speed, coordination of fine and gross motor function, impaired mobility, speech and swallowing dysfunction, and then non-motor, cognitive impairment, fatigue, neuropsychiatric concerns such as depression and anxiety, sleep disturbances, sensory dysfunctions such as pain, loss of smell, and vision problems, as well as autonomic disruptions such as temperature regulation.
All right, moving on to the stages of Parkinson's disease. So there are 5 stages, but they're kind of split up into 3 different categories of early, mid-stage, and advanced. So at your screen, we have the Hoehn and Yahr scale, which is utilized to identify stages of the disease based on primarily motor symptoms and also their level of independence to take care of themselves. So as you can see, the top part that's in orange mostly talks about motor and presentations of the body in those stages, and the bottom addresses the symptoms that you'll typically see within those stages as well. All right, at this time, we would like you to pause the video and either click on that link or scan the QR code to participate in the Jamboard activity. On the left side of your screen, you'll be able to add a sticky note, and you're going to answer the question of what occupations may be difficult considering the motor and non-motor symptoms of Parkinson's disease.
There is no true cause for Parkinson's disease. The way that it affects your brain is dopamine producing neurons break down. And then when you're not able to produce enough dopamine, you're not able to have regular brain activity. So that leads to the problems with motor control. At this time, research has shown that genes can play a small role. It's very rare, but there are genetic markers that indicate an increased risk for Parkinson's disease. And then there are also some environmental triggers. Again, it's a very small likelihood that these are going to cause Parkinson's disease, but common exposure to toxins, pesticides, or pollution does have the ability to increase an individual's risk for developing Parkinson's.
So the prevalence for Parkinson's, as you can see in the image, 1.2 million people in the US will be living with Parkinson's by 2030. And based on the image, certain states are more prevalent to have individuals with Parkinson's. And men are about 1.5 times more likely than women to be diagnosed with Parkinson's disease, as well as a majority of the studies have reported that there's the highest prevalence in white populations. For medical management, there's no one-size-fits-all treatment for Parkinson's disease. It's often tailored to an individual's symptoms, and it's a shared decision-making process with their healthcare providers and their team of professionals. There's therapy and mostly physical activity that's a modality, such as PT, OT, and SLP, which help with the voice disorders, tremor, and cognition, as well as we promote diet, which is just healthy eating habits, which will also be discussed in the precautions slide ahead. Exercises such as aerobic activity, strength training, balance, agility, and multitasking and flexibility can strengthen muscles and improve balance, flexibility, and coordination, as well as there's been some evidence on massage therapy, which can reduce tension within the muscles of individuals. For medication, this is the main medical management. So individuals often take levodopa, which is a pill that is absorbed in the blood from the small intestine and travels through the blood to the brain, where it is converted into dopamine. And then they also take carbidopa along with levodopa, which often reduces the nausea that levodopa can cause. Other common medications that they can take are dopamine agonists and amantadine, and the other ones listed there, as well as surgical treatments such as duopa, which is a form of carbidopa-levodopa that's directly injected into the intestine rather than using the pill, as well as individuals can undergo deep brain stimulation, which is stimulation of specific areas in the brain that control movement, which often can help with the tremor, paucity of movement, and rigidity.
All right, now for the precautions. Because Parkinson's is unknown, there is no gold standard strategy for ways to prevent the disease. But what we can do is focus on environmental factors and other personal factors that can influence our lifestyle and way of living to help prevent as much as we can, even though there's no research supported way. So, our first strategy is diet. So, focusing on whole foods like vegetables and fruits, along with lean proteins, beans, and whole grains with a nice balance on your plate. Colorful plates are always helpful too, to make sure that you're fitting in all of those different categories, and also making sure you drink lots of water and stay hydrated. And then exercise also plays a big role in this. So making sure that you are getting exercise in some form every day, getting the body moving and help build strength, endurance, balance, and coordination, since those are affected from the symptoms of Parkinson's disease. Aerobic exercise is popular within this diagnosis because research indicates that getting the blood pumping helps that brain tissue and build up protective mechanisms. All right, moving on to our assessments. The first assessment that we found in research as the most evidence-based was Unified Parkinson's Disease Rating Scale. So this scale has 4 parts addressing non-motor experiences of daily living, motor experiences of daily living, motor examination, and motor complications. And there are 20 questions that are completed by both the patient and the caregiver. This is only used for individuals diagnosed with Parkinson's disease and are 18 years or older. The appropriate practice setting for this would be either outpatient or home health, because it assesses that current level of functioning that they're at within daily activities of daily living within the environment that they are currently at for a more permanent setting. And then the emphasis on focus that's relevant to occupational therapy assistance. This assessment would be appropriate to be administered by an OTA because it is non-standardized. However, even OTRs and OTAs who administer this assessment need to receive certification from the Movement Disorder Society so that you understand the boundaries and basics of the assessment. And the results should always be interpreted by an OTR. And for best practice, this assessment clarified that it should be used in conjunction with the COPM, which we will discuss more later. And then here on this slide, we have some sample images of what the assessment will look like for the client and caregiver survey areas of the assessment.
Another assessment commonly used to assess health and function in individuals with Parkinson's disease is the Parkinson's Disease Questionnaire 39. This is another self-report measure with 39 items that assess Parkinson's disease-specific health-related quality within the past month. This assessment measures 8 dimensions, including ADLs, attention and working memory, cognition, communication, depression, functional mobility, quality of life, social relationships, and social support. This assessment is appropriate for use and is commonly used in a variety of settings, including inpatient rehab, skilled nursing, home health, outpatient, and even community-based settings. This assessment should be used in adults and older adults diagnosed with Parkinson's disease. There is no specific training required to administer the assessment. Health professionals, including both OTRs and OTAs, are able to facilitate this assessment. Remember that this is a self-report measure and individuals self-report the results for each question. In accordance with appropriate practice guidelines, an OTR should interpret the results and collaborate with the OTA and other members of the care team to establish or update an appropriate plan of care. This is what the PDQ 39 form would look like. You can see sample questions here, such as difficulty doing the leisure activities which you would like to do. Individuals rate their answers on a scale of never, occasionally, sometimes, often, or always.
All right, our final assessment that we're going to talk about is the Canadian Occupational Performance Measure, or better known as COPM. So the COPM can be used for a variety of populations or diagnoses, including individuals with Parkinson's disease, and the individuals need to be ages 6 or older. The appropriate practice setting for this would be outpatient or home health setting because it assesses their current satisfaction within ADLs for their current, more permanent environment. The emphasis in relation to OTAs, this assessment is appropriate for OTAs to administer because it is non-standardized and it does not require any prior training or certification to become competent in the material. The results should be interpreted by the OTR you're working with, and for best practice, it should be used in conjunction with the MDS UPDRS that we discussed earlier. And then here we have an example of the COPM where they talk with the therapist to outline their most valued occupations, and then they rate their level of satisfaction within those occupations.
For the first intervention we're going to cover, we're going to talk about the LSVT BIG program, which is the Lee Silverman Voice Treatment BIG Therapy. It can be administered by trained and certified therapists such as OTs and PTs, and OTA could also be certified with this program. It includes large amplitude multi-directional exercises that help revise participants' perception of their own movement. They use maximal effort movements to override the hypokinesia or the slow movements that they're witnessing through repetition and sensory feedback and individualized functional task practice to facilitate translation of skills to successful performance of daily living activities. Components of the program would be maximal sustained exercise, which is often done when you're sitting, repetitive standing movements, so you move from sitting to standing, functional task components, so relating it to certain activities within the patient's daily life, hierarchy tasks, and then it often ends with big walking or gait training. And it's usually a 1-month program, and the sessions are 1 hour, 4 times a week, 4 weeks in a row. And there's daily homework and carryover exercises that are addressed in each session.
Now we have our second learning activity, some practice with some LSVT exercises. Go ahead and follow this link to a YouTube video posted by the Parkinson's Foundation and follow along with the therapist to perform set 1 sustained movements. Another intervention supported within the literature for individuals with Parkinson's disease is multidisciplinary intensive rehabilitation treatment. As described in the name, MART is multidisciplinary, aerobic, motor cognitive, intensive, and a goal-based rehabilitation treatment program designed specifically for Parkinson's disease. The goal of this program is to relearn dysfunctional movements resulting from the disease through the use of both explicit and implicit learning strategies. The treatment program is specific to inpatient rehab and follows a frequency and duration of 4 sessions per day, 5 days a week for 4 weeks. The first session is usually one-to-one treatment with PT. The second is focused on the use of devices to improve gait and balance. The third session is an OT treatment session to improve autonomy in everyday activities. And the fourth session focuses on speech therapy. OT interventions used within the scope of this treatment program vary on patient needs and current level of functioning, and they include things such as ADL training, hand and finger exercises, bed mobility, transfer training, self-management strategies, adaptive equipment and/or strategy, recommendation and training, including ADL training with adaptive equipment. OT interventions are provided by members of the OT care team, including both OTRs and OTAs. For best practice and best outcomes, collaboration between the OTRs and OTAs should occur in order to modify and make changes necessary to a patient's planned care to maximize their rehab potential. A systematic review by Doucet et al. Found that strong evidence supports the use of multidisciplinary intensive rehabilitation treatment to improve ADL performance, and moderate evidence supports its use to improve sleep performance. Anticipated outcomes for LSVT big treatment, as discussed in Doucet et al. 2021A, include improvements in functional tasks requiring fine motor skills, improvements in gross motor function, and improvements in ADL performance. Secondary outcomes also include improved occupational performance and satisfaction. Outcomes in this study were reflected by changes in the box and block test, as well as the Unified Parkinson's Disease Rating Scale. Anticipated OT-based outcomes for multidisciplinary intensive rehabilitation treatment, as discussed in Doucet et al. 2021B, include improvements in ADL performance and independence, improvements in sleep performance, and improvements in hand dexterity skills. The majority of assessments and measures used in the study were the PDQ-39 and the UPDRS. When considering discharge planning, it's important to take the client's desires into consideration and where the client wants to go. It's also important to consider their safety with and ability to perform various occupations, as well as their level of evidence and available caregiver support. There are a variety of possible discharge environments, including inpatient rehab, long-term care, skilled nursing, home health, and outpatient services. This will vary based on the patient's current level of functioning. For example, if an inpatient individual with Parkinson's disease demonstrates adequate progress, it may be recommended that they continue with home health services or outpatient services. For individuals living in the community and with a higher level of independence, a referral to community programs is essential to promote their continued independence. A development of a home exercise program may also be relevant.
So now we're going to look at modifications and adaptations for individuals with Parkinson's disease. There are 5 main areas that we wanted to address. The first one being dressing, and we have mealtime, adaptive equipment and tools, self-care modifications, and then home safety modifications. So within dressing, it becomes a lot of adapting the clothing that you're wearing. So replacing shoelaces with no-tie laces, replacing shirt buttons with magnetic or Velcro closures, wearing non-slip shoes to reduce the risk of falls, and then adding large zipper pulls to jackets or coats. And with these modifications, it's just going to increase ease of getting dressed with the tremors and the motor difficulties that are being experienced. During mealtime, the biggest focus is going to be reducing the risk of aspiration for the patient. So keeping a consistent mealtime routine, eat frequent small meals rather than 3 large meals, just so that you're not trying to get so much down at one time. Incorporating milkshakes or protein shakes to add nutrition to your diet while decreasing the risk of aspiration, And then using adaptive utensils such as utensils with built-up handles, modified dishware, or steady spoons to increase independence within feeding. And lastly, avoid talking or multitasking while eating to reduce the choking risk. Next, we have adaptive equipment for all areas. So we've got memory and visual aids such as calendars, alarms, and schedules, just to keep individuals with Parkinson's disease on track for their feeding, any appointments that they may have, as well as medication management. Then we've got things such as recreational aids, so larger adapted cards to be able to play card games with family members or friends, card holders, and then the use of audiobooks to allow individuals to enjoy the hobbies that they previously did without increasing frustration due to the tremors and the motor function. Using a walker or a cane to aid with mobility while participating in daily occupations, and then adding in a medical alert system or smart device within the home. So if you do experience a fall, you can alert somebody and get the help that you need. For self-care modifications, it's looking a lot at different ways within the bathroom to make sure that you're still performing the hygiene that you need. So the first one is creating a routine for bowel movements. Individuals with Parkinson's disease tend to experience constipation quite frequently, so making sure that you're on a very consistent schedule. And then one of the recommendations is also just to take your time. So cut out time to be in the bathroom, even if it doesn't feel like you have to go, keeping very regular within that schedule. It's just going to increase bladder control and bowel control. Performing self-care routines while sitting, so this includes in the shower as well as brushing teeth, doing your makeup, doing your hair, and that's just going to reduce fatigue. Once again, adding built-up foam grips to handles to make it easier to control with the tremors. And then using a shower chair aids in bathing and allows for frequent rest breaks, as well as reducing the risk of falls in the shower since that's a naturally slippery area. And then last thing we have is home safety modifications. So for this, you just want to be modifying your home to be as safe as possible. So removing tripping hazards from the home, including rugs, cords, and then clutter. Installing handrails in the bathroom and on the bed to aid in mobility in those areas. Adding non-slip mats to slippery surfaces such as hardwood floors or within the shower or bathroom, and then increasing lighting within the home, especially in the hallway areas. You can get lighting that's motion censored, so at night you're not fumbling for a light switch, you just have those automatic lights so that you're reducing the risk of falls in that time. So then once again, if you could go ahead and pause this video and scan the QR code to take the post test and see how much you learned from watching this video. We have also provided you with some additional resources for Parkinson's that you can use to look up and educate yourself further, or that you can provide to individuals with Parkinson's so that they can get the support they need or the education that they need. Those resources are the American Parkinson's Disease Association, the National Parkinson's Foundation, the Michael J. Fox Foundation for Parkinson's Disease, and the Parkinson's Resource Organization. Here are our references that we used. Thank you so much for listening to this presentation.